Members, if you could take your seats. Councillor Richardson, Councillor Hack. Thank you. While members take their seats, I will welcome everyone here to today's meeting of the Health Overview and Scrutiny Committee. I would like to remind everyone present that this meeting will be broadcast live via the County Council's website and will also be available for viewing after the meeting. I would ask anyone, if you have a mobile phone, that you make sure it's on silent. And can I ask also people talking to make sure they switch their microphones on when speaking and then turn it off when they've finished speaking. Thank you. Now we'll move to the agenda. Agenda item 1, minutes of the meeting held on the 19th of June 2017. I do propose that the minutes of the meeting held on the 19th of June 2017 are taken and read, confirmed and signed. Do I have a seconder? Okay, thank you. All members in favour? Okay, thank you. I'll sign those at the end of the meeting. Agenda item 2, question time. I can inform you that I've not received any questions from the public. Agenda item 3, questions asked by members under standing orders. I have not received any questions from members. Agenda item 4, to advise of any items which the Chairman has decided to take as urgent elsewhere on the agenda. Again, I've not been told of any urgent items that we need to take. Agenda item 5, declarations of interest in respect of items on the agenda. Do any members have any interests that they wish to declare? Councillor Hack.
I just wish to declare an interest on paper A, please. Personal interest. I live in Braunston Town. I'm a deputy town leader of Braunston Town Council.
Okay, thank you. Okay, thank you. Agenda item 6, declarations of the party whip in accordance with the overview and scrutiny procedure rules. Do any members have any declarations? No, thank you. Agenda item 7, presentation of petitions under Standing Order 36. I have not received any petitions for today's meeting. Agenda item 8, our first report. This is the summary plan for the future of primary care health services in the North Blaby area of East Leicestershire and Rutland Clinical Commissioning Group. You'll find this on pages 13 to 18 of the agenda. I'd now invite Tim Sachs and welcome him, the Chief Operating Officer for East Leicestershire and Rutland Clinical Commissioning Group, to present his report.
Thank you, Chair.
Welcome,
Good afternoon,
Tim.
everybody. Thank you very much for inviting me. I've been asked to come and talk about primary care in a particular part of our area. The last meeting I came and spoke about the GP 5-year forward view, the impact of the work that we were doing overall. But I know particularly there are some concerns that have been raised regarding an area that covers around 60,000 people in the North Blaby area, covering the area of Leicester Forest East, Glenfield, Narborough and Enderby into Braunston. So this really is just a high level, it's not a detailed plan, and this has come about from having a number of conversations with town and county councillors in relation to what is the plan to look at the healthcare in that area. We know, and has been mentioned before, that we've had some significant issues, both in relation to sickness, in relation to numbers of GPs, in relation to premises. And actually, in some cases, there's been a little bit of a perfect storm in some of the areas, whereby we've had very few GPs to cover the population, and we have buildings which are covering, housing 10,000 patients, where really they were designed for significantly smaller numbers. This also does cover the particular question about Thorpe Astley and a community centre that was built and the rooms for healthcare, and how that will then link into the large increase in number of houses being built in the Lubbersthorpe area, which could increase the population by a significant proportion. So really what I've come to talk about is the fact that there are some issues that we have raised. And specifically, what are the plans for what we're going to do? It is one of the most deprived parts of our geographical area as well. And I am in negotiation. I'm having meetings next Monday and ongoing to discuss with councillors to look at what is really, to use an expression, the art of the possible for the area, to make sure that we look at the appropriate recruitment, that there is the appropriate premises, and that we future-proof the healthcare service. There has been a lot of noise in the system about the care that people have been getting, and we have been working very closely with the practices to try and support them. What I can report back so far is that there has been an increase in the number of clinical staff, although they have been nursing staff rather than GP staff in a number of the practices. And we have a programme of international recruitment, which you may have heard about in the press recently, about how we can support bringing GPs into the whole Leicester, Leicestershire and Rutland area. And two of the practices in the area have been very keen on seeing whether there is an opportunity for them to take on additional GPs from that. There are also opportunities for developing buildings within the area. The Warren Lane surgery has been successful in a national bid to extend their premises. However, we do have one of the premises which is coming up for their term has expired, and that building is looking likely that it will be sold, where in the past over 8,000 patients were being offered healthcare from that building. It does leave a big gap in the particular area. So there are some significant questions that need to be answered, and working very closely with elected colleagues, I think it'd be very important to actually come up with a detailed plan. And in a way, it works as a blueprint of how we're going to work across all of our areas, because general practice is more and more working more closely together. We have a number of areas. North Blaby, or the practices we're talking about here, is a very good example of how we will be moving towards a type of multi-specialty community provider, which puts groups of general practices together working with community services and with social care services to enable a more wrap-round service for our patients. And the North Blaby practices are starting to work very closely together to look at how they would like to pilot that in East in a way that has already been done in some other areas. For example, our West Leicestershire colleagues have been moving towards that with their federations. And it's how we develop that model, which is really very much the national viewpoint of how healthcare should be provided in a community setting. So there are some real opportunities with this, and some funding available through NHS England stipulation that we should be funding our practices to transform the way that they deliver care. I've also asked our Health Watch representative from Leicestershire, Sue Staples, who sits on our Primary Care Commissioning Committee, to support us with looking at a survey of patients in the area, which asks a different set of questions than we normally would from the GP survey, which is very specific, to actually help us to really understand a little bit more about how we could develop this type of service for patients in that area. So I think the reason it's here, normally it would be more on a general basis of healthcare, is that we have a particular area which is in need, and we'll be supporting it very much to look at how we can use that as a model going forward for some of our other areas as well. But there will be a full detailed plan which will be worked up with elected colleagues and Health Watch colleagues as well to push this forward, and we'll be happy to bring that back if that was requested in the future. And I'm happy to take any questions.
Okay, thank you, Tim. I'll open it up to questions for members. Councillor Parton.
Thank you. In your comments a few minutes ago, you used the word noise. Okay, there's been some considerable noise. Could we have a clarification, please, on exactly what you mean by that? Are we talking complaint? Well, the first question is what you mean by noise.
That's a very good point. By noise, I mean there is. We've had the most recent National Patient Satisfaction Survey results back, which have given us a very clear understanding of people's views of the services that they're getting. We have spoken to each of the patient participation groups in the area to understand, and we work closely with them. And I'm meeting with the patient reps at a joint patient participation group meeting tomorrow morning to have that discussion. Also, in relation to particular complaints about one of the practices where we know there are a number of GPs that left and the access problems that were there, and by talking to your colleagues, your local authority colleagues, and them informing me of some of the information that has been coming from the area, and there was also a petition that was done from a group of patients, which was given to Braunston Town Council, which was then forwarded to me.
Oh, thank you. And do you intend to, as a performance model, log the number of complaints and see whether the plans you're putting in place will bring those numbers down?
We take all complaints incredibly seriously and have a very clear process, and my colleague, who's the chief nurse and deputy MD of the organisation, Carmel O'Brien, sitting behind you, is our lead for quality and takes those incredibly seriously with our process. Complaints come in many different forms, whether they are local practice complaints or complaints that actually are serious incidents that we have to investigate in a lot more detail. But of course we take all complaints very seriously, and whether informal through the survey or formal complaints to the practice or ourselves. And yes, we would like to hope that if a service improves and people are happy with it, then there would be fewer complaints, but they may be of all different types.
But, so, how useful do you think it would be to publish the complaint levels maybe from now for the next year while the plan's developed?
I am of the view that I think complaints are in the public domain, not the actual complaints themselves, but the numbers are in the public domain. And I'm getting a nod from behind you, which is very helpful for me to clarify that. So, yeah, we will. I mean, I think judging the complaints, depends the complaints on what. If it's complaints on access, complaints on being able to get an appointment, if it's those, then that would show very clearly that there was an improvement in what we were doing. So we would like to make sure that there was an improvement across the board. But yes, complaints would be looked at clearly.
Chair, is it worth requesting those with the other figures as well as part of a package?
Apologies, it would help. We report to our governing body all of our
Yeah, sounds useful. Yeah, thank you.
I think we have a governing body paper going next week.
Okay, so it's historical, but yeah, it'll give us a measure. So, okay, thank you for that. Councillor Hack.
Hi, thanks, Tim. Just a couple of points, really. On point 20 of the paper, identified that Kingsway put forward an expression of interest for international doctors. As I understand it, the surgery itself has 2 GPs and 4 clinical nurses, which is down from 7 GPs, which is where the capacity issues are. I think also within the paper itself, there seems to be quite a lot of mention of expansion of capacity, but this capacity expansion seems to be outside of Braunston Town rather than we're trying to resolve the issues of capacity locally. How will the CCG consider improving services locally rather than look to Warren Lane?
Warren Lane is obviously part of the area, and there was a bid that was put forward to expand those premises. Because there is a need to expand those premises, and nationally the bid was put forward and was successful. But that is an element of the whole question. We have to look at all of the premises in the area, and as I mentioned before about the Kingsway premises, and with the building in Leicester Forest East most likely not still being available, that leaves a big gap in the geography, and having plotted it, you can see there is a big gap there. Part of this plan is to look at, is there a need in relation to the existing population as well as new population in relation to buildings. And one of the conversations that we have had is, well, is there more that could be done, for example, with the community centre? Are there other rooms that could be used as an expansion possibility? So there are a number of different areas that we need to look at, which will form part of this plan. It's we're very lucky to have got national funding on it to expand a particular practice, but as you said, that's on one edge. But it doesn't mean that there won't necessarily be looking at the premises across all of the other areas as well, which is every intention that we have. That answers one of the questions, doesn't it? The other one is about staffing.
Can I just come back to you?
No, sorry.
In terms of the expansion of Warren Lane, that is not going to improve capacity issues in Braunston Town. Warren Lane is already problematic for patients in Braunston Town to get to. It's already offered and rejected by several patients when they want to go to the surgery that Forest also operate on the Braunston Crossroads. we have a lot of elderly people that live in that part of Braunston Town, and going up to Warren Lane at the moment to them is already prohibitive. So closing down a surgery on the Braunston Crossroads, which is maybe what will happen, and moving capacity to Warren Lane doesn't solve the issue of reducing capacity across Braunston Town, which was the actual concern that Braunston Town residents had. So it was more that I would like to see how we will address the capacity issues, particularly in Braunston Town, alongside the other areas of North Bellay Bay.
From my perspective, I look at the whole of East Leicestershire and Rutland, and I understand, of course, that Braunston Town is the particular area that you're focusing on. When it comes to looking at this, we're looking at the whole of the North Blaby area, which will include everywhere from Enderby and Narborough up to Braunston and covering that whole area. I absolutely understand that there is a question about why aren't more services being provided on the Forest House surgery. And I think I've explained that, that lease has come to a close and it is likely to be sold, and there is nothing we can do about that. What we can do is look at how do we re-provide and make sure that it is accessible for patients, which is the question we're trying to answer. However, the bid for Warren Lane did go in now 2 years ago as part of the national funding. It was successful, and it is funding that has come nationally, which will then be used. But that doesn't preclude us from then looking at other areas or how we can look at expansion of capacity for the patients of the North Blaby area.
Councillor Richardson.
Thanks, Chair. I'm really pleased that this is being looked at, Tim. Obviously, being from the area, there's an awful lot of issues to be resolved. However, the area for the 6 GP practices is quite a large area if patients are going to have to be moving from one place to the other. And I just want to point out that we have another issue in the area in that Arriva have been closing bus routes down. We already have people going from Thorpe Astley into the town, into Leicester City, to get back out again to access their GP surgeries. And whilst it's not a specific issue for you in your role, that has to be included in all the debate around this to ensure that those who can't drive or who with illness can't travel far still have that accessibility.
I completely agree with that. It's interesting because when looking at it, when looking at a geographical area, it is about the most geographically aligned of the group of practices. And if we look, for example, at the Melton Borough, we go from Syston as far as Long Clawson and first past Grantham. So again, there are always access issues with everywhere that we look at. I think the key thing for this is about actually doing the mapping of the current premises, because we know there are some key issues. This was asked to be brought here because actually it's a bigger question. There's obviously the question of the North Blaby area, but also how are we looking overall at health services and the development and design of models that are going to work for patients. But what we do have is a number of practices who want to look at how they support each other and work together and provide services together, but they have to have the appropriate premises to do it. I think part of that, we do need to talk to your council colleagues in relation to travel. We have no input and say-so when it comes to bus routes, but obviously it is important for patients to be able to access healthcare in the same way as it is in rural areas.
Councillor Fryer.
Thank you. Thank you, Mr. Sachs. I'd like to ask a question regarding paragraph 30 or point 30 on page 16. You're currently conducting a 12-week consultation. I just wondered when this consultation commenced and when it's expected to be ended and when you expect to be able to produce the results of it.
I think the terminology, I apologise that we're not actually undertaking the consultation. It is the practice who are undertaking the consultation. What we have done is supported the practice in relation to making sure that they follow due process and get to speak to and contact as many people as possible. It is their consultation. Just in brief, this is a surgery who have 600 to 700 patients in Narborough. The main, although that is the main surgery, the branch is on the Narborough Road, 193 Narborough Road in the city. The GP from there also has 2 other practices in the city, and he's looking at how he can consolidate those. And that would mean that actually, as a standalone basis with 700 patients, it makes it really it's too few patients. To be able to have the clinicians there to provide an 8 to 6:30 service, which he's contracted to do, does make it incredibly difficult. The consultation started, I believe, 2 or 3 weeks ago. I apologise, I haven't got the exact date. But what will happen is the full 90-day process will take place. We will then see all of the information will be duly analysed, and then the public primary care commissioning committee of East Leicestershire and Rutland CCG, which takes place monthly, will then look at that and debate that in public. To work through what the implications are and whether we believe from the consultation that we can approve the application by the practice to close that particular surgery.
Okay, thank you.
Dr. Hill.
Thank you, Chair. I think from what I've seen in the report and what's been said, there isn't really a plan yet. It's evolving, and I think the local members are going to want to keep an eye on what happens to see if it goes in the direction that residents will be comfortable with. But you sort of say you quite rightly thinking as well about the overall view. I mean, it's not like Lubborsthorpe just appeared out of the ground like a mushroom overnight. It's been going on for a while, same as Thorpe Astley. So I'm sort of got thinking, well, you may have seen this coming. I know you have a 5-year view, but maybe with the sort of strategic growth plans that are kicking around and proposals for this, proposals for that, how far ahead should you be looking and getting the practices to do succession planning, maybe 10, 15 years out, so we don't come across... And I think this sort of thing will probably reoccur elsewhere in the county as big housing developments come on stream and everybody else suddenly wakes up to the fact they've got 50% more people on roll than they thought. Thank you, Chair.
Lubborsthorpe is a really interesting situation there because the pace of which the houses are going to be built means that we are probably somewhere between 5 and 7 years from getting adequate levels of Section 106 monies to be able to do anything about it. And therein lies the problem, in that actually, suddenly, if there were 2,000 homes built overnight, of course that doesn't happen in reality, there would be enough money, we'd be able to put a health centre in there which would provide those services. It's that balance between when are there too many people, even though the Section 106 isn't available, and when do we actually need to do something else. But that's just one element to it, because it's such a slow progress. And we have the same in other areas as well, that the Section 106 monies never come along in adequate amounts to enable us to be able to build a new health centre. In relation to succession planning, what happened in one of the practices, particularly Kingsway, was a bit of a perfect storm. They lost 5 partners in a year. And then the last 2 partners who were there decided to move on and join other practices. So there has been enormous change, and that's something that you couldn't plan for, that level of change. And actually, through funding from the CCG and through support and working with them, I'm actually very proud that the practice haven't gone under, because it really could have done. And I'm very pleased that we've been able to work with them to start the rebuilding process. And it's not finished by a long way, and there are still issues there. But the fact that it's still open and providing healthcare, I think, is a minor success story in a very, very difficult circumstance. But in relation to all of the areas, there is a move towards practices working more closely together to provide services and to support each other, because of the pressures on general practice and the issues with workforce as well, means that it's both a necessity and one which should absolutely improve access for patients in the long run, because there are currently in places some real gaps.
If I may, Chair, I mean, I accept the point about a partnership falling apart. That isn't expected, but you've been involved, you corporately, not you personally, are involved in agreeing what Section 106 for the developers. So there's an argument you can easily take from things like this for future 106. Say, can we have the money a bit sooner, please?
I agree.
And I think if you did that, I think the planning authorities would probably welcome that as well, because I think, certainly for Lubborsthorpe, I think you could solve a few problems around the district as well. So there's no other questions. One question I just had was you talked in the report about some of the Leicester City CCG reducing the boundaries of their practices. Is that something you can control? I'm just aware that quite a large part of Glenfield go to a city provider at Oak Meadow on Tatlow Road. And of course, if they decided to reduce their boundaries, then you'd obviously have more of a demand on that. So is that something you work together with?
We do work very closely with our colleagues in West Leicestershire as well as City CCG. However, it is not something that we have direct control over. And I will take an example of the Leicester Forest East area, where a city practice boundary did overlap, and they covered 3 of the care homes in that area, and they changed their boundaries to be the ring road between city and county, and therefore stop looking after those care home patients, which put increased pressure on the Forest House Medical Centre. It is one where we do work very closely together, but and I think as joint working goes, it's one of the key ones to make sure it doesn't destabilise another practice. But it is an ongoing issue of boundary changes.
Thank you. No further questions. Can I thank Tim for his presentation, and look forward to welcoming you back again in the future, no doubt. Thank you. If I may now, items 9 and 10 on the agenda are presentations, 2 reports, continuing healthcare settings of policy from our 2 clinical commissioning groups of West Leicestershire and East Leicestershire. So what I'll do, a lot of your agenda pack, pages 19 to 82, you had the report from the East Clinical Commissioning Group, and on pages 83 to 136, you had the report from the West. I think I've got them in the right order. So, all right, back to front. I've decided to take them together. So, members, if you can hold any questions you have, if they're specifics. Really, the reports in the pack, a lot of duplication. Obviously, we've got a single-page summary on the one, and we've got an 8 or 9-page summary on the other. But so, if members could hold back questions, I have invited Caroline Trevithick, who is the Chief Nurse and Deputy Managing Director at the West Clinical Commissioning Group, and Carmel O'Brien, who's the Chief Nurse and Quality Officer, Deputy Managing Director at East Clinical Commissioning Group. So I'll invite them both to present their reports. Caroline, if you'd like to go first, and then we'll sure have some questions for you.
Thank you very much, Chair. Caroline Trevithick, Chief Nurse from West CCG. The paper that you've got in front of you describes the process that West Leicestershire has been through to come to the position it is at the moment around the settings of care policy. I understand lots of members around the table are new to Health Overview and Scrutiny Committee, but there have been previous reports to Health Overview and Scrutiny to ensure that people are aware of what we're trying to do as a CCG, as 2 CCGs, and how we've been taking it forward through consultation, etc. So just a bit of a summary. Carmel may well repeat me, but the purpose of the policy is to define how and when CCGs support the choice of care settings for individuals in relation to safe, effective and clinically appropriate care that makes the best use of available resources. So the policy is around ensuring that we've got a process to do that. We've been on this journey for quite some time now. We've made a decision in our March board to agree in principle to some of the changes, but we felt that there was still work to be done. And then in our July board, we received an update, and unfortunately we weren't able to make a decision at that point. Again, board members for West Leicestershire CCG asking for further information around the potential scale of the impact, and so we've gone away to undertake that piece of work. So the paper describes that process and hopefully brings you up to date with where we are from a West perspective, and I'll just hand over to my colleague.
Thank you, Chair and members, and I won't repeat what Caroline said, but just to put some context, I did come to Health Overview and Scrutiny Committee. I think Sarah probably was the only person that has a memory, but so just to confirm that we hadn't anticipated it's being brought earlier, but of course because of PERDA, that's why we had a delay into the summer. Without sort of repeating, as Caroline said, East Leicestershire and Rutland CCG did approve the policy in their July governing body. Unfortunately, and maybe my error because I was on leave when the papers were submitted, but the formal policy for East is not the one that's in your pack. That was the one that was presented to board. So on our public website, the final policy is available along with the equality impact assessment that was made available prior to our governing body discussion about implementation in August. You have an appendix which was the implementation plan I presented in August to our governing body. I think the important thing for the committee to understand is that a number of the actions, this is a high-level action plan that needs to take place, are joint LLR actions that are already in train between the 3 clinical commissioning groups and Midlands and Lancashire Commissioning Support Unit, who, as you will be aware, is our new provider of commissioning support services, including thinking about principles for how we apply exceptional circumstances, and our colleagues from Leicester County Council Public Health Department both Drs Mike McHugh and Dr Tim Daniels are supporting us in developing those processes. And you can see that there's a number of sort of operational things around standard operating procedures and disputes resolution process that we need to work through as part of that plan. There is a workshop planned for later this month between the 3 CCGs to try and unpick some of those pathway issues and to have some plans in place to have implementation across the health economy to tighten up on some of the gaps we've had. So I probably will stop there and allow for any questions from the Chair.
Questions? Councillor Fryer.
Thank you, and thank you very much for the reports, which did take a while to read through, but I did read them. Yes, I'm afraid there were a lot of duplication. I'm just interested in the distribution list for the consultation document and the information. I'm looking at page 52 and page 116, which covers both areas. And I was disappointed to see that in the media, it's exactly the same in both, but no mention of the Loughborough Echo, which, bearing in mind, that covers the second largest after the city town. It's the only paper that really does concentrate on the Loughborough area and the villages. It also, of course, obviously includes, we have a large population, it's a very diverse population, it's very well read. I've noticed sort of 3 media people in Rutland, great, and Harborough had 2 and things like that, but I would have thought the Loughborough Echo was a vital conduit to get information out. And I'm just wondering whether there was a particular reason that wasn't done.
So just from a perspective of handling the arrangements, the process that we have in place across the 3 CCGs is that we take responsibility for our own particular areas. And maybe Caroline can pick that about the Loughborough Echo. But to put in context, the arrangements that were in place for engagement and also for consultation. So we wrote to every single patient who was in receipt of continuing healthcare at that time. We made the consultation documents available in a number of formats, and we offered opportunities for telephone interviews. We also then, as organisations ourselves, have a key stakeholder list, if you like, in terms of the people that we would send that information to, be that papers, radios, and MPs, council colleagues. So, and the list that you have is the list of local services, as well as it being available to members of the general public through Twitter feeds, through our general stakeholder stuff. We also send it to Health Watch Rutland. So whilst I can't account for the fact, and obviously Caroline may be able to help, we very often will send everything to every newspaper, but it's only if they choose to come back to us and publish it that we can't enforce it.
Yeah. Thank you, I appreciate that, but I would have been very surprised if the Echo hadn't picked up on this. And if they hadn't, I mean, I would have hoped that you would have had this list, and then if the Echo didn't respond, you just wrote against it, no response, or that wouldn't print it or something. But I'm presuming that all these people are the only ones, the way the report's written, my presumption is that this is who it was sent to. It doesn't mention other places that didn't. So I just feel all I would say is it's done now, and this has happened, but in the future it is a major line of communication for residents in not only Loughborough, but all the surrounding villages, which is a key area.
If I may respond to that, obviously the information is the information. I'll need to go back and check, I'm afraid, because it isn't just the Loughborough Echo that's missing, it's the Ashby Times and everything. West Leicestershire have got a really good reputation of engaging with our media stakeholders. including Oak FM and other areas. So what I'd like to do is take that away and just confirm where it went to. There is a bit of an issue with the fact that we do know that we send information to lots of media outlets, and they don't seem to take it forward. I think that's a good piece of advice to us to say at future consultations, identify where it hasn't been taken forward. But I will get back to you on the list from a West perspective. Okay.
Thank you. Councillor Taylor.
Thank you, Chair. I don't know who wants to answer, it's probably to both of you, but I am a little bit concerned about patients that are already receiving continuing healthcare and how that's going to impact on them. Within the report, it's saying that existing parents will be subject to the new policy upon their review, whether it's 3 months or a yearly review. And obviously, what's going to happen to those patients if they are reassessed and their care package is way above the 25% and they need to get to the 10%? Are they going to be forced to move care homes, forced to move, and totally change? Or if they are receiving care at home, that they'll be forced into a care home? So I am like some clarity on what's going to happen and the impact on patients that might have to alter because their needs and be moved to somewhere that they don't really want to be moved. And should this policy just be relating to new cases, and people that are already receiving this care shouldn't be put through the trauma of having to alter their care package?
So if I just start, so the policy applies to when the policy will be implemented, it will be applied to people who are deemed eligible for continuing healthcare packages. For those people who are currently in receipt, it will apply if their clinical needs change. So it's not quite as black and white as you describe, and I referred earlier to our colleagues in the Public Health Directorate here are helping us to work through, because this is about safety, patient safety, people having a choice and in the personalisation agenda, and it is about making it sure that the package of care for that individual meets their needs, but that it is safe for them to do so in the setting they're at. So if their deterioration in their condition is such that it is no longer safe for them to be able to remain in that place, we will look to ensure that we're able to provide that care for them in a setting where it is safe. So this isn't as black and white as if it costs X, we're going to move you. That is not behind this policy at all. It's about ensuring that when someone's complex condition and the nature of that condition fluctuates to such an extent that it is no longer safe, we will, with our clinical colleagues through our high risk and complex care panel, be clear about whether it is safe or not for them to remain in that particular place of choice.
I think just to add to that, there is the issue around the personalisation agenda, as Carmel just mentioned. So we currently have a settings of care policy, and we currently have these conversations with patients all the time. And one of the things that we've really been able to take forward with patients is personal health budgets. So looking at providing care in a different way that sometimes works out at a different cost, because people are able to manage those budgets in a different way, that we're not tied to the same kind of arrangements as we are with some of our other care packages. And we've got quite a lot of success in taking forward CHC personal health budget packages where people feel much more in control of the care that they're being provided. So this plays into this as well. It isn't just a case of just looking at cost, it's about safety, it's about risk, but it's about choice and personalisation as well.
Thank you for that. Can I so if someone is in, say, a care home and their needs are not changed, but they're above the 10% threshold, they won't be moved then, they will continue as they are at review. Is that correct?
Sorry, if needs have not changed, there will be no movement in that package.
So they'll be continued to fund even though they're above the 10% threshold. So it's only if someone's care needs change that this new policy would affect them. Okay, thank you.
Thank you. Councillor Richardson.
Thank you. I was just wondering if you could tell me how often you do review your policies, because I realise this policy you're reviewing now is from 2011, and there was an internal review done in 2013, but we're now at 2017 and are still doing consultations. So we obviously have a gap somewhere of having a policy in place, do we?
No, actually, the policy that we referred to in 2011 is the policy that we've been working to from a CCG perspective. So we inherited it from the Primary Care Trust, the predecessor organisations. There was a recognisation in 2013 when all of the CCGs we were classed as first wave authorised bodies, that it was a piece of work that we needed to do. It was really clear that the policy was not fit for purpose because it did not take into account personal health budgets, but we were also really clear that it was such a complex and sensitive policy change that we needed to understand the data behind any changes, and that we need to be really clear that we're able to engage with people. So it has been a really long journey. We had the engagement event with patients last summer. The output of that formed the consultation, and I think it's really important that we took our time and we were very clear about getting as much information from people in receipt, the general public, the various committees, through local authority, through our membership, through our colleagues in Health Watch, to be able to come to the right decision for patients.
Thank you.
Councillor Parton.
Thank you. If I may ask a few questions regarding the actual process of the consultation. Thank you. The first one is, how was the actual process of the consultation managed? Because obviously there are lists of who was contacted. Was it done by yourselves, or was it contracted out to a private company to run the consultation and to actually project manage it?
That's fine. That's okay. Okay, so what we do as 3 CCGs, our communications team come together with a project plan for any be it engagement we're going to do, and in this case a formal consultation. So they agree the principles of what we're going to do. We for this exercise, we were very clear that it needed a formal consultation with members of the public and members in receipt of. And as CCGs, we have contracts with our commissioning support units, and those are the bodies that, and in this case it was Arden and Gem commissioning support units that undertook that formal process, because we were really clear that we need to be transparent and be disconnected from us, so there was no challenge about questions coming back to anybody within the CCG. So the report that you have, which is the same report in both the West and the East's paper, is the report that was provided by Arden and Gem as a result of the exercise they undertook on our behalf. So they handled the arrangements in terms of questions coming back to them, counting up the numbers, doing the analysis and that sort of stuff.
Right. So in terms of the actual way that the reports, the statistics are presented, the observation that I saw, and so obviously I will be asking for whether this is because there's legislation that controls this, or whether this was a decision that was taken. A lot of the actual, apart from the postcode listing of responses, a lot of the figures are regarding sexual orientation, ethnic group and age. But what there isn't, and bearing in mind there's a long list of charities that deal with various health problems, there isn't any indications of the people that responded, of your demographic makeup, of the needs, the actual needs, the conditions that the people had that responded. You know, there's lots of information about their ethnic or sexual orientation, but was it not considered a factor worth considering, that it was to see what people were actually, you know, the reason for their care? For example, you know, how many people had a mental health problem, how many people had been infected by a stroke, how many people had Parkinson's, and so on and so forth.
Okay, so The purpose of the consultation was around the change in threshold. So when we undertake a consultation, it is about being clear that we are targeting the groups that are going to be directly impacted, as well as, in this case, members of the public for ELR CCG, West Leicestershire CCG and the City, who all have a, if you like, a vested interest, thank you, in terms of the money that is available to buy health services for the whole of the population of LLR. So certainly when our governing body looked at the draft consultation questions, we were very clear that there was a group of people in East who are in receipt of continuing healthcare who we absolutely need to directly write to, which we did, but that actually there was a wider cohort of people, which is all the residents of ELR, who we would expect and would ask to contribute to the consultation exercise. Your question about targeting people, it's not as simple. Because you have a stroke or you have Parkinson's does not mean you meet the threshold for continuing healthcare eligibility. So there is a process that we go through in determining somebody's needs. There's 9. We can perhaps provide the link to the continuing healthcare framework if it would help people. But there are a number of domains around behaviour, nutrition, mobility, cognition, and then on top of that there's an application in relation to the intensity, the nature of your condition, how that fluctuates. The other 2 areas the unpredictability, how unpredictable your condition is, and the frequency of that. So there is a whole process that is undertaken to come to a point of your needs are so complex that you meet the threshold for receipt of this funding, and that means that healthcare provides your care at 100% NHS funding. Within that package, it may be that you have some personal care needs which would deem to be social, not health, but health have the responsibility to provide that. Does that help?
Personally, I think I would have to really go away and think about this a little more, because I understand what you're saying, and it was a very helpful answer. But the point is that these organisations were contacted. I would have thought, because many of the service users would have had contact with these people, and I would have thought that, you know, the point X is to reach the standard of care that you want for anybody that has the issue, or was the exercise here to actually to see what the makeup of the people, and this was only the makeup of the people that actually responded. Of course, there may have been ethnic groups or an age of person that just would not be interested for whatever reason that they have, or reasons that they didn't feel they either wanted to or felt it relevant to reply to the consultation, just no matter how good the consultation is. And unfortunately, of course, that's pertinent to all sectors and walks of life, isn't it?
I'll have a go. So, as Carmel said, the important bit about consultation is getting out to the people who it might affect. So the reason to go out to the interested groups, those with the vested interest, isn't just to get their opinion. It's an opportunity for them to share it with people that they interface with as well, because
Yes.
they can be used as a bit of a go-between as well as bringing back their own opinion. Writing out to individuals who are in receipt of continuing healthcare was important to both CCGs to do that, to ensure that we maximised our opportunity. But just leaving it that, we knew that we wouldn't get the responses that we needed. So having a list of relevant stakeholders that we could do as well is really important to do that, because they might be advocates on behalf of the people in receipt. So they may be returning their views, not saying whether or not they're the specific condition that the individual has, but relating them back because of how it might affect their lives, irrespective of their condition. And that's the kind of impact that we wanted to get back to. The information that we collect from an equality perspective is something we have to do with everything. So it's a standard process that we have to make sure. You would be coming back to us and saying you haven't done an appropriate assessment of whether or not you've got a good equity across the consultation that you did. But I think it's the balance of trying to contact the individuals themselves, getting the key stakeholder groups to make sure that they can act as conduits or provide their own opinion, and then putting the wider message out to the public, and hoping that that together brings a response back to us that we can then interpret.
Okay. All right. Well, thank you very much. That's made things a lot clearer. The last question is not, please, I repeat, not meant to be a trick question, but in terms of the cost of the exercise and the time taken, on a scale of 1 to 10, how satisfied are you that it was value for money?
Do you mean the consultation?
Yeah, that's right.
I guess I would say we absolutely have a duty to consult with members of the public, and when we are making such a change to a service, and it's absolutely right that we did that. And as a result of doing the consultation, we were able to apply what people told us into the policy changes that we agreed in our governing body in July.
Okay. Can I thank you, Carmel. I think you did say when you came to the table that this committee actually looked at this consultation back in January, these January meetings, and made comments. So we are sort of re-evaluating the consultation. So, but I think the answers you've given there are very good. So I've got a couple more questions. We've still got a couple more presentations, which I'm quite keen to move through. So, Councillor Hack.
I've got two, hopefully relatively small points. And I'm sure the quality impact assessment may well have answered this. Do we understand, do we have an understanding of the numbers of the individuals that wouldn't have been successful in getting a package between the 10 and the 25%? So had they been evaluated today, how many people would that have impacted on? And of all of the Appendix 1, which is the settings of care policy thresholds map, have those areas been evaluated in terms of outcome for the patients when the thresholds go down to 10%?
So, in response to your first question, it is not possible to predict when someone will deteriorate, and this is not. And if you go down that route, you end up in perhaps a financially driven exercise. So, it is about understanding when an individual's clinical needs change. Is it still suitable, and is it safe for them to remain in their existing place? And so from our perspective is very much this is about clinical safety and understanding whether we can continue to provide a package of care for an individual when their needs change, and these are very, very complex needs. So there will still be people receiving care with high cost packages because it is absolutely the right thing for that individual, and they may choose to do it through a personal health budget. They may choose to do that through various choices of place of setting of care. So it's not as easy as you would imagine, and if you try to go down that route, you're not meeting exceptional circumstances. So if you have a list, it's not exceptional. Does that make sense?
I was asking, it was more about if we were to, the individuals who are in service today who don't meet the 10% threshold, do we have an understanding of what proportion of the budget or proportion of individuals that wouldn't meet the criteria today had they been reassessed? But also, it was around evaluation of outcomes, or when the thresholds go from 25% down to 10%, do we understand what the outcome for the patient might be if they obviously would no longer qualify?
So this brings us to the reason that the two boards have come to a different decision. And as Carmel said, it is really difficult to forecast that because it's done on a case-by-case basis. So looking at our total spend on CHC, we couldn't say it would affect 10%, 5%, 1%. That's impossible to do because you have to take every case by case. So the piece of work that West are taking forward is to see whether or not we can get any idea of the types of patients, not the numbers. I think it's the types of patients that we might then, this policy might then generate a different conversation with the family, with the individuals concerned. I think it's really difficult to put a number on it because it's so individualised as we take the policy forward.
And finally, Councillor Richardson.
Thank you, Chair. You sent out 1,300 copies of the document to people who have needs, but you only had 212 back. And yet, from your pie charts, 112 of those said they didn't consider themselves to have a disability. So have we actually got sufficient relevant data for this? Sorry to ask the question, but I just want clarification.
So having a disability isn't a criteria for continuing health care. So the question in the consultation document is in the same way as any of us that would, if we're applying for a job, do you have a disability, that kind of a question. So I think it's about the question that's asked. So I think it's back to my response to Mr. Parton in terms of the fact that we wrote out to the individuals concerned in receipt of health care. It isn't about a disability, it's about people being in receipt of it, all those stakeholders that interact with people who are in receipt of or who might be in future receipt of continuing health care.
So do you have a breakdown that are these 212 surveys all from people with care needs?
So they will be a mix of people who are in receipt of packages of care, members of the public, any of the organisation who chose to respond.
And I think that's where my original question came in. Have you got sufficient of the people who are, needing care packages feeding into this consultation?
Okay, well, so our governing body in East is confident that we have, and the legal advice that we've had in relation to this has satisfied us that we absolutely have taken all of the reasonable steps possible to be able to have undertaken a good consultation process. It is very tricky to get people to respond, and I know consultations at the local authority undertake, and we have one in public health at the moment. It's very difficult. People will choose to contribute if they have an interest, or they will choose not to. So we have to take assurance that we have taken our best endeavours, if you like.
Okay, thank you. Can I thank Caroline and Carmel for their presentations and questions. I think there was a comment at the beginning about the final policy wasn't the correct one in the documentation. So I think if for East, so if that could be sort of sent through to us, that would be good. And yeah, I'd like to thank you both for your answers and your presentations. Thank you. That does complete agenda's items 9 and 10. We now move on to agenda item 11, and we're now going to have an update on the new emergency department at Leicester Royal Infirmary. This is a follow-up to the report the committee received on the 1st of March before the new emergency department opened. And Tamsin Hooton, Director of Urgent and Emergency Care at Leicestershire and Rutland CCGs, is going to give us a presentation. So welcome to Tasmin. It is indeed, thank you.
Okay, and I've got my clicker. How long have I got?
I think the question is as long as it takes, but
Okay,
I would hope so. Yeah, let's see how we go.
Make myself comfy then rather than brush. Okay. So I hope this presentation is at the right level, but please do either kind of speed me along or ask me for more detail if it's not. So the first slide I have is just kind of a summary of the position in LLR historically and some of the highlights around the performance of the urgent care system, which historically has been poor and not delivering good quality of care to our local residents. The key issues for us are very long waiting times at the emergency department at Leicester Royal Infirmary, the performance against the national 95% standard of people being seen within 4 hours was 79.6% for the last financial year, and the year to date, when at the point I was writing this presentation, was 79.5%. Historically, we have seen periods where demand growth for urgent care has been very high. We seem to be moderating that demand growth now, which is very pleasing, but that has been a factor in terms of pressure on the urgent care system over the last couple of years. And that has led to both long waits at ED, but also long ambulance handover times at the LRI. There's a national target for 15 minutes for ambulance crews to hand over a patient to the care of an emergency department team. We were doing very badly against that target in the last financial year. At the moment, about 49% of patients are being handed over within the 50 minutes, and that is a really dramatic improvement to what we were seeing in the last financial year. So some aspects of our emergency care performance are getting rapidly better. Where ambulance handover times are long, though, that contributes to long response times by the ambulance service, and I've got my colleagues from EMATH here, and I think they probably want to say more about that later. So that has been a factor of performance in LLR over the last couple of years, and performance against the categories, kind of the old red 1 category in the last financial year was 67.2% against target 75%. So all that kind of combines to give you a picture that we've got a struggling urgent care system that is leading to kind of poor patient experience and sometimes very long response times and wait times. Having said that, we were seeing some really positive signs of improvement in March and April of this year, immediately prior to the opening of the new emergency department at the Leicester Royal Infirmary. The opening of that new department saw performance drop quite dramatically, which obviously was not what was planned or hoped for, and I think we're still in the position of catching up from that performance drop. So you can see there that the performance against our local trajectory for improvement in April was green, so we're slightly ahead of the plan to improve towards the 95% target. And you can see on the little graph of the dip that there's a sharp decline through April, immediately after opening of the new department, and late April and May performance was really just, no other word for it, appallingly bad. So waits got longer and ambulance handover times lengthened extremely over the last week of April and the first week in May particularly. Having said that, there now is a month-on-month gradual improvement. Haven't put the figures in here, but the final figure for August was 83.4%, and September month to date is 86.2%. So we are starting to kind of inch up closer to where we wanted to be by this point of the year. So the key issues that underline, I suppose, both the ongoing performance challenges and that real drop in performance in late April and May were, some of them were to do with features to do with the opening of the new emergency department. So I don't know if people have been around the new ED. I know that some people have had kind of tours around ED. So, I mean, it's significantly bigger physical space, and the Majors suite in particular is really quite significant. I think it has 36 beds. But in the first few weeks of opening, some of those beds were being used by the GP assessment unit. So the planned Majors capacity wasn't on stream, and an approach to moving GPAU out of that space had to be found, which it was at the beginning of May, and that led to a hike in performance immediately. There were also quite a lot of process issues in ED, although the Trust had planned over a long period of time to move into the department. They hadn't really been able to walk through live the procedures in the new space, and it was a much bigger space for staff to operate in. And some of the processes, particularly around what we call the front door, the assessment zone, were really different. Staffing capacity is a long-term and significant problem for UHL, both nursing and medical, particularly overnight. In comparison to daytime. And if you look at the timing of when the long waits happen, generally they happen sort of after 8 o'clock at night, and they can be having quite a good day in ED until going into the evening, and suddenly you start to get sometimes up to 100 patients breaching the 4-hour target all in the overnight period. So there's something about both processes and capacity in the overnight period, and I'll talk about actions that are being taken to address that a bit later on. So, move on to some slightly better news. Got a couple of charts here that show ambulance handover performance. And there's been a marked increase in the number of patients that are being handed over to ED within the target time of 15 minutes. So the national target is that 100% of patients should be handed over within 15 minutes. We can have a debate about whether that's ever completely attainable. But you can see back in April, that was less than 35% of patients were being handed over within that time frame. By July, it was 48%. And actually, I think, and Mark, I think, can confirm the August figures, but it was over 50% in August, and the average preclinical handover time is almost, well, it's between 15 and 16 minutes at the end of August. So that actually puts LLR and the LRIED very much within the kind of better half of performers in the region in terms of ambulance handover times, and that is the first time I think I've ever been able to say that in this room. So, you know, some things have really changed since the new department came on stream, and, you know, it was built to enable that to happen. It would have been really disappointing if we hadn't seen that happen. They've got 14 handover bays as opposed to 8 in the old department. The major space is significantly bigger, and there's a much bigger ambulance assessment zone. So, you know, we expected this to happen, and we have seen the improvement. And that has also led to a rapid decrease in the total lost hours, and that plays directly then into the ambulance service's ability to get out back into the community to patients who are waiting for attention. So I've got quite a lot of detail in the rest of the slide pack about some of the issues and actions underpinning performance. I don't need to talk through all of those things. If it's just too much detail, I'm happy to take questions. But I think that the key things that I'd like to pick out, because there's probably a couple of points on each of the following slides that I'd like to say. The delivery board, which is chaired by John Adler, Chief Exec of UHL, has got a recovery action plan, and it's split into 4 key areas: inflow, emergency department flow, hospital flow and discharges, and I've tried to outline some of the things we're doing in each of those areas. In terms of managing demand at the ED, this is one of our success stories as well. So I said earlier that historically we've seen significant, you know, in excess of 5% a year growth in ED and emergency admissions. We, as part of the Vanguard work that we did last year, and I've come to this committee a couple of times to talk about that, we introduced clinical navigation last December, and that meant clinical assessment of patients calling through to 111. And we have seen a reduction in both emergency department referrals and green or less severe ambulance dispatches as a result of that clinical navigation service. And so in the first 4 months of this year, we've seen emergency department attendance has dropped by 2.2% compared to last year. So we're really pleased that we're not seeing rapid demand growth, because that takes some of the pressure off ED. The Trust is doing a lot of internal work around its ED waiting times and ambulance handovers. Some of you may have seen in the Health Service Journal or in the press that they're currently in a fortnight, what they're calling September surge, where they're pretty much throwing everything at process improvement within ED. That is including putting on additional medical capacity, particularly overnight, to try and resolve some of the overnight staffing issues, and trying to really kind of operate, if you like, a perfect fortnight. That has shown some improvement over the last week. So the first 2 days of the month were over the weekend, and on Sunday, actually, the Trust exceeded the 95% target for the first time in many months, which was great. The rest of this week has been a little bit more challenging, and yesterday's performance in particular was poor. I could give you more detail on the reasons why that's been the case, but certainly, you know, the week so far has been one of the better weeks that UHL has experienced in quite some time. And I think the Trust is really trying to show leadership in terms of getting over the message that A&E is not just the A&E department's problem, that the whole hospital contributes to flow through the hospital, and that everyone has their part to play in what looks like an emergency department problem. Oh, and then, oh my God, do I have to go all the way through it again? And finally, on discharges, we have we've seen quite a lot of improvement in the length of stay at UHL and the number of patients that are delayed due to external reasons or detox as a result of an initiative called Safer, but also improved interface processes really between social care, continuing health care, the CCG urgent care team and the hospital. And we have weekly escalation meetings, and we also have daily kind of reporting to try and hunt down all of these delays. So we do still have a problem in terms of meeting the national detox target of 3.5% in Leicestershire. And you may be aware of that in terms of the Better Care Fund. But we have looked at the problem in quite a lot of depth in terms of where the excess delays are, and actually they're in mental health and learning disability clients. They're not in patients at the on the UHL wards, and UHL's detox rate is actually lower than the national target of 3.5%. So I think increasingly we're putting our attention where it needs to be rather than where perhaps the national attention is in respect of detox, and we've seen some success in relation to the trust external delays. So I suppose in summary what I'd say is it's a slightly improving picture, but it's absolutely not where we wanted to be, and where I think local residents would expect it to be.
Okay, thank you for that. It's interesting, in the information-only papers we had a copy of the Health Watch Leicestershire checking at the new ED emergency department, and obviously it's interesting seeing what the patient's view of the facilities are, and I think there was some interesting sort of quick fixes almost from a sort of patient's perspective as to what could be done. But as I say, it was that's an interesting report. I think September surge is we saw that again, as I say, it's been in the press. I mean, if it worked for the weekend, then it's not so good during the week. It's been interesting, hopefully a quick fix to do that, but basically I'd say that's probably down to resource and having the resource in the right place and the numbers that you need. So it's
well, I think the Trust has really tried to get the resource there to see what happens when it is in place. We've had a meeting with John Adler this morning. His diagnosis of the problem is actually they fixed some of the problem. What they haven't fixed is some of the operational processes between ED and the admitting wards, so that even though they may actually have free beds, patients are not getting out of majors into those beds in a timely way, and that ought to be solvable. Sometimes it's about process, and it's about information available to managers to get the patient to the right bed in a timely way. So it isn't all about resources.
I'll open it up for questions. Councillor Parton.
I'm not sure whether you'd have these statistics or it's something you may be able to present as part of the figures in a future meeting, but since the new opening of the ED department at Leicester Run Infirmary, how are the figures or the weight, the times that patients who presented with mental health problems either see the crisis team and or a psychiatrist, whether the times that people who are presented with a mental health crisis, whether this new system is helping to speed up the time that they're seen?
I don't have the figures on me about numbers of breaches that relate to mental health patients. You're probably aware that for most A&E departments, mental health patients can be some of the more difficult to treat in a timely way because of some of the complexities around assessment, and they may not be in a state to complete an assessment when they're admitted. I don't think, mental health hasn't been raised as a particular problem on the opening of the new department. I am aware that sometimes there are constraints in terms of the number of physical cubicles that are available to do mental health assessments, and that can slow down people's waits or mean that people have to be kind of held in the majors' cubicles. I go away and find out that information, but I don't have any more detail than that at the moment. It's not been raised as a particular problem on the new department.
Yes, Chair. I mean, thank you very much for that. I'm particularly interested in the sort of the time before someone is seen by the crisis team, particularly, or or a psychiatrist, because of course, a percentage of them won't be admitted onto a psychiatric unit. So that's the sort of real figure I'm quite interested in, if I may. Thank you.
Presumably that's something that could be provided statistically.
Attributable to patients who've attended for mental health reason compared to the average number of breaches gives you an indication if they're getting faster or slower treatment.
Okay.
Yeah, thank you very much.
Okay, thank you. Rick?
Yes, thank you, Chair. I'm conscious that quite a number of members of this committee are relatively new, and so I can repeat myself and be a bore. But as your Health Watch, our broad, the cultural position we've tried to take with service providers is to be critical friends. I think the situation around ED runs the risk of testing that relationship. When we visited in June, the unit having opened, I think, on April 26th, we were very, very impressed with the physical infrastructure. The difference was quite remarkable, and the thought and the research that had gone into it was very, very impressive. We made some recommendations. We reported those to a quarterly meeting that we have with UHL, and to the best of my knowledge, those are in train. So I think, broadly speaking, the physical side of this is excellent. With my daytime job, I've been involved in many new buildings, from bus stations to hospitals to offices to goodness knows what, and rarely do they seem to work properly on day one. So that's my softening up comment, if you like. But I can't deny that now that we're into early September, and even though we all dampened down expectations that this was going to be a magic bullet, I think we all have to be very disappointed as to where we are at. And I know that John Adler and the team, and Tamsin, I'm sure you feel the same. I'm not stating anything that you have not said yourself. I think the most important thing is inevitably in analysing where we are, where we're at, having a reality check that we've still got the winter to face, where inevitably performance figures do go down for pretty obvious reasons, particularly if we get a bad winter. Acknowledging the complexity of A&E and ED, that it isn't just a question of building a new £48 million building and opening the doors and everything will be tickety-boo. It's around the performance and availability of GPs, isn't it? It's around the performance of 111. It's around changing attitudes of people with regard to pharmacy, etc., etc., etc. So that magic bullet certainly won't happen overnight. But if there are three elements to a new building, and again I think you've alluded to them, Tamsin, if there's the physical building, the physical resource, if there's the processes, and if there's the people, I know that the NHS is absolutely strained in general around people. I'm not sure that anybody in senior management is going to deny that. There's a shortage, isn't there? Perhaps the disappointment might be that the processes haven't worked better. I mean, with respect, I think with the September surge, John Adler, in a letter to staff, properly populating rotas. I mean, to me, that's great speak, but it means having the right people in the right place at the right time. And this argument that in the evening the system isn't resourced well enough, with the greatest of respect, I would have thought that senior management knew that back on day one. There's a difference between not getting the resources in and not having the resources. So right here and now, we as a Health Watch will play whatever role we can in educating people about when to use A&E, but that is a bit like turning a ship round in the middle of the Atlantic, I suspect. We'll play every role to be constructive and helpful. But these are really worrying issues, aren't they? Because if we don't all, and we're all part of this economy, get this right, then there'll be other people who've authorised 48 million of spend breathing down our necks. So I wish you well, but I am concerned just coming into the winter that 5 months after the opening of the All Singing All Dancing ED that we are where we are. And I think I'd be failing in my duty if I didn't make those comments.
Thank you, Rick. Councillor Richardson.
Thank you. I'm partly on the same line as Rick. You say staffing capacity is one of the major issues, and particularly overnight. Now, my question was going to be, is that lack of resource or management of resource? And if it's management of resource, then that should be being dealt with a lot quicker, in my personal opinion. Because at the moment, people are being redirected to 111. There are walk-in centres, and therefore we've seen that there is a slight reduction in those attending, and yet we don't seem to be addressing the issues that are being highlighted, and especially coming up for winter, etc., when you know you're going to be overrun again. I also, through personal experience of things, think that in the hospitals in general, a better communication between the departments, and you were saying about people going on to admission wards, that people seem to work more in silos almost in the NHS, and it would be great to get that communication going across the different departments.
So I think you're absolutely right about the relationship between different parts of the hospital, and I think that increasingly UHL are honing in on their diagnosis of what the fundamental problems are for them. And I think if John Adler were here, he would say we absolutely now recognise that the key reason why our performance is poor is within the walls of the hospitals. It's not confined to the footprint of ED, though. It's about the interface between ED and the rest of the hospital. It's about the speed of senior decision maker coming down to ED to take a view about patients, and it's also about the processes to then get patients admitted from majors into the hospital. So I think you're absolutely right, and those things are complex to solve, but they should be solvable without too much additional resource. The staffing resource issue is a fairly long-standing one, but I think one which has come into a bit more kind of sharper relief since the move into the new ED. Some of it is around not just the bodies you've got on the ground, but the skills of those bodies. So whether it's nursing skills to undertake certain tasks, which limits their effectiveness, even though you might have the bodies on the ground overnight, they're not able to undertake the full range of patient treatment, and therefore people are waiting, and you've got somebody there that's not able to treat them. Or the availability of medical staff, which is more difficult nut to crack potentially for the hospital, because they have to renegotiate with the consultants and the doctors their job plans, if you like, and their hours of working. But that is something that they are actively engaging in. It's just not necessarily as easy as just saying, I'm going to put you down for these hours, because consultants have their terms and conditions.
Okay, thank you. Councillor Taylor.
Thank you. You've probably just answered a little bit of my question, but it was just about that you're aware of your issues, you know where the problems lie. So mine's a bit more of a forward plan as to how what the plan is to address those issues, and when you think you're likely to hit the national targets that you should be hitting, and what's in place for the future rather than looking backwards.
So the immediate target is to try to get to 90% this month, to get back on the trajectory towards the 95% target. The national expectation is that the majority of trusts hit 95% by December of this year. Given where we're starting from with Leicester Royal Infirmary, there isn't a commitment to hit 95% by December of this year. And in fact, the commitment and the trajectory locally is to get to national target by the end of Q2 next year, which would be the end of September in 2018. And, you know, that's... In some ways that's really disappointing, but other ways that's realistic given the speed of improvement that we've seen, and given that we saw a really significant drop in performance as a result of opening the new ED. I would like to say we would improve faster than that, but I think it's better to be realistic rather than to set targets that aren't achievable. We do have a range of improvement actions that we monitor every fortnight within the delivery board. We are under intense scrutiny from regional NHS improvement and NHS England on that. And the plan is constantly being revised as we try one thing, work out if it's effective or not. But I think the important thing for us now is to kind of, if you like, not get distracted from what we have done, which is kind of really narrow the focus of the problem and concentrate on internal processes within UHL.
Thank you. Dr. Hill.
Thank you, Chair. I think I can remember when this was first mooted as the fixer of problems, because we were at the bottom of the national pile, and that's how we effectively got the money to build it. And it was going to be the sort of answer to everybody maiden's prayer until sort of, I think I might have said to Toby Sanders at one of these meetings, well, are you sure it's going to fix it because you've got a lot of process issues? Well, maybe not. And then reality's kicked in, I guess. I think what Rick said was very apposite. With winter coming, you've got a lot of things to sort out. I think the organisation's massively siloed. Usually on the wards at night, you've got one houseman running about 6 wards. So getting that person down to A&E, and they're not an expert. I think you've got some sort of personnel challenges, and getting people out of majors, because my limited experience was some of the wards like, we don't want them, go away. So there's all sorts of things to be sorted out, but I think you're in the right direction, because I think finally, now you've got the new building, they realise it isn't the building, it wasn't the lack of beds, it must be the hospital. And everybody now, in terms of the staff, particularly the clinical staff, I suspect, have got to accept that and deal with it. So that's good. I'm pleased you're sorting out handovers, because that's been a perennial issue for our colleagues at EMAS, and that's good, it's getting better. I'm actually pleased that attendances are going down, because that's the first time in ages. It's been growing year on year for ages, and that's good. I also thought it was interesting in the Health Watch report how most of the people had actually been the GPs and referred by the GP to A&E, which I thought, well, that's interesting, because everybody go to your GP first, don't go straight to A&E, and they're doing it and going to A&E as well. So there's lots to go at. I picked up your last slide, the discharges and delayed transfers of care. There was an acronym I didn't recognise, which is HT-LATH, whatever that is, or LAR. And then because I'm a bit of a statistician nerd at heart, the little grey, well, it's on your thing is orange on the screen, and ours it's red. There's an interesting pattern of the number of bed delays. And why does it do the pattern it does? Why does it go up and then suddenly drop within a week or so? Is that because everybody goes, oh my God, the figure's gone up, let's all look at it? Or is it because that's when social services measure it? I mean, there must be a reason for that pattern, because it's a very clear pattern. I don't know whether it goes on year in, year out. I was just curious as to what that meant. And also, because there was a rise in the county and the impact of something I didn't understand, so that was another question.
Lots of questions. I thank you for your early comments, but if I miss one of your questions, will you remind me? HTLAH is Help to Live at Home. So that is the council sort of integrated domiciliary care discharge support service that was tendered for last November. the procurement was a bit rocky, and they weren't able to award contracts to as many providers as they needed in the first round. So it did lead to a kind of squeeze on domiciliary care capacity over November and December, particularly last year, and that did lead to a rise in delayed transfers of care for county patients. So that's what that is about. I've looked at that kind of pattern as well, and I potentially we should try and correlate that to other things, as I am not sure why it does that pattern, with the exception that when things get really bad, we have an absolute purge, I think, and I don't know if it is just to do with that. If that were for LPT, what I'd suggest it relates to is very long stay clients being discharged, because what happens is every month you get another 30 days added on to that person's delay, and then if you discharge that person, the figure plummets. So in LD at the moment there are 3 clients, each of which has a year's length of delay. So when that person is discharged, your bed days delayed drop. So maybe it's part of some of that is getting the long stayers out. But it's an interesting question, and I don't have a definitive answer.
Thank you. Councillor Hack.
Hi, I've got just a couple of questions. We obviously look at the 4-hour delay. Do we understand what our 5-hour, 6-hour, 7-hour? Do we know how, on average, how long it's taking for throughput, I suppose? Personal experience, my father-in-law had a 9-hour and a 14-hour wait. So do the excesses get investigated? That would be sort of just a quick question on there. And I've lost my train of thought. I'm sorry. Yeah, if that would be great.
Answer that, and it might come back to you. So we do investigate very long stays. So if there's more than a 12-hour wait for a bed, that's seen as a serious incident, and there's a root cause analysis done. But more generally than that, I think what UHL are now trying to do is say, look, if people have to be admitted within 4 hours from majors, what should be happening in the first 30 minutes? And so really trying to develop standard procedures. So this is what you need to do in the first hour, not suddenly someone's been there for 3.5 hours, we need to find them a bed, because you're kind of fighting a losing battle when you approach it like that. So yes, long waits do get investigated to identify trends, and I think the Trust is absolutely trying to move to more standardised processes to avoid 4-hour wait.
It's come back to me, sorry. Does the 4-hour clock start ticking at the point at which the ambulance hands over the patient, or when the person is waiting in an ambulance?
It's from the point in time they're clinically handed over to the ED team. So we were disguising very, very long waits for patients previously, but the incidences where patients are waiting, well, more than 50 minutes is much less now, but more than 1 hour waits are very unusual now at LOI, or fairly unusual.
Okay, thank you for that. Any more questions from members? No? Okay. And hopefully, Tamsin, there is some good news there. Obviously, we've purged and we've surged. I think we've put some challenge in there, and I think we've obviously heard some good information. I mean, I think your September surge might need to become an autumn assault, and I think it'll need to continue. I mean, perhaps if John can come up with some names for No, thank you very much for your report. Thank you. Agenda item 12, we now move on to the Care Quality Commission inspection of East Midlands Ambulance Service. Mark Gregory, who we met last meeting, General Manager at EMAS for Leicester, Leicestershire and Rutland Division, will present the report, supported by Kirsty Morgan, Head of Infection Prevention Control at EMAS. So, welcome to both of you.
Just while Kirsty's getting set up, I'll just give us a quick introduction. As you've already said, we the last time we visited, we spoke of the Care Quality Commission's inspection, but hadn't had the report findings back at that point, so committed to coming back and sharing with you all. I think it's a positive report that we've had back, and Kirsty in a moment is going to just share those findings. And I'll summarise at the end. So I'll just hand over to Kirsty, who's our Senior Quality Manager. I think I've got that correct.
Push the right button, it helps. So as you're aware, we were inspected by the CQC during February and a further unannounced inspection in March of this year. They published their report in June. When they came in to review us, they didn't look across the whole service, but they did look at the safety and effectiveness of the emergency and urgent care services, the safety and effectiveness of the Emergency Operations Centre, and the safety and effectiveness and well-led at a provider level. So from within the report, you'll be able to see that the 3 of the 5 domains that were tested were rated safe, was rated as requires improvement. This is progress from the May 2016 rating of inadequate. Effective requires improvement. There was no change in that rating from the previous report. And well-led requires improvement. Again, no change. From our previous inspection, our ratings for caring and responsiveness domains both remain at good. So, despite sustained challenges, the CQC recognised that we've made significant improvements since November 2015, and these included care and professional staff delivering compassionate, patient-focused care despite the challenges due to the continued demand. Joint working arrangements with other NHS and blue light organisations improving accessibility of patient services, particularly those located in remote areas and for patients who require mental health care. A sepsis pilot in North and North East Lincolnshire, providing prompt life-saving treatment for sepsis patients. A highly effective recruitment campaign which received a national award for equality and diversity in recruitment. It did recognise that we had some areas for improvement, and in order to address those, we've developed a quality improvement plan. The plan has been approved by the CQC, and the action plan and all of the actions are within the information that you've been provided with. We have regular one-to-one meetings with the CQC to discuss progress against the quality improvement plan. And our quality improvement methodology was approved by NHS Improvement. We have a trust improvement board that monitors against the actions against the plan as well. In addition to this, we've developed and had approved a 2-year strategy to take the trust from requires improvement to good from a CQC rating. So you've got a number of actions in place there as well.
Thanks, Kirsty. I think in written form, it probably doesn't do it necessarily justice. When I say it was a positive outcome for us and a positive inspection, it was positive. We lifted the improvement notices that we'd been given, and the journey that the organisation had taken were recognised by the CQC. At the quality summit that followed the publishment of the report, the CQC fed back that we were bordering on good as an organisation. The only thing that was holding us back from being good was that our performance against the Red 1, Red 2 and Red 19 standards as they were then were underneath or below the national standard. Slightly disappointing because at that point we weren't commissioned to deliver national standards. We were commissioned on a locally agreed trajectory. But nevertheless, the CQC had recognised the journey that we were taking and continue to take in relation to those improvements and the findings that came out that prompted that re-inspection. Clearly, we've taken another step along that journey now in terms of moving on to the ambulance response programme. At the point of us moving on, it was a pilot. It's now no longer a pilot because government or the Department of Health have commissioned and signed up to all ambulance trusts moving on to the ambulance response programme, or ARP. And that's really about making sure that we're commissioning and delivering care which is based against patient outcomes rather than stopping a clock at a certain point and monitoring against percentages. We're still in the early stages of that. We're still moving through it, but the early indications are that, again, that's positive in terms of performance against time taken to achieve patients, as well as positive ambulance quality indicators as well in terms of cardiac arrest and survivability after cardiac arrest, management of myocardial infarctions and stroke. So we are on a journey. I think we recognise that, but we're fairly positive and optimistic, as are the CQC. I'll pass it out to questions.
Councillor Richardson, thank you.
Thank you. It's good to see some improvements coming through. Can I just ask about your action plan, because it's from February, March time. Only we've got the implementation date for the R1, R2, etc. 31st of March 18. Seems a long way ahead for seeing some improvement on that. Just you can explain for me. Also, things like arrangements for Trust Board members to complete an annual declaration for fit for proper person, and that's down for the 31st of March 18. I wouldn't have thought it needs a whole year for things like this. When it's such an important thing to be getting our services up, these sorts of things could be done, I would have thought, a lot more easily, as well as implement and deliver mentorship and associated training plan with the implementation date again March 18. Surely I would have suggested that working with staff now would be a good way to start.
Thank you. I'll try and remember which ones we had. I'll come on to the fit and proper persons initially. That's complete. So you're quite right. It was an action that had got an implementation date, but has been signed off and is complete. So we're quite comfortable with where we are with that. I think the other one was around Red 1 and Red 2 in terms of recognising improvements. That's almost been superseded with the introduction of ARP. The reason that the date was set as 31st of March 2018 was we were undergoing a demand and capacity review which was being independently undertaken by a company called ORH Limited, who do a lot of work with ambulance. Well, they do work with all of the ambulance services across the sector, and that was to identify what our activity was, what efficiencies we could make within the current setup, what revised rotas might look like in the future to drive maximum efficiencies, and how many additional staff we would require to deliver national standard at Red 1, Red 2 and Red 19. Their findings were that as a trust and across the trust we would be needing somewhere close to 500 to 550 additional staff. So it probably gives you some idea and indication of the challenges that we were facing as an organisation to meet national standards. Clearly that position's changed now with the introduction of ARP. So ORH are just doing a revised piece of work with us to understand how many additional staff we need to meet the new response targets and standards. That will be will be a lot less staff, so we'll be nowhere near 500 staff. But they're about to conclude that piece of work now, and we're also entering into a rota consultation to support that. And I forget what the last point... Okay. So we already have a very clear programme in terms of mentoring new staff that come in. However, there's been a change in terms of the banding of paramedics from, if you like, they moved up a band within the pay structure of the NHS. What that's done is introduced what we now call newly qualified paramedics, and that's required a change to the way that we mentor and preceptor new staff coming into the organisation. We already had a very good process in place across Leicestershire, Northamptonshire and the rest of the organisation. And I say Leicestershire, Northamptonshire, sorry, because that's the areas I'm responsible for. We already had a very good structure in place. We've had to revise that slightly, and working with our education colleagues, we're now moving to more of a facilitated education and practice education model, as opposed to just a core mentorship role without outside on the operating on the role. So people flow from education out into the divisional structures. So it's more holistic and feels a little bit more of a wraparound mentoring and preceptorship for our new staff.
Thanks very much for the explanation.
Councillor Parton.
Don't worry, that these aren't too taxing. But for clarification, on page 151, where you have the chart at point 15 at the last inspection, the ratings for the trust were set out below. And then at 16, the CQC rating following the latest inspection are as follow. Now, this goes over to the next page, 152. Now, if you go back to 151 at point 12, it says inspections will be based on the 5 key questions used previously. So if we've got 5, what's the reason in point 16 on page 152 that there's only 4? So overall trust rating, there's 1, 2, 3, 4 columns. Presumably this follows on. Does this follow on from this? So does that follow on from that?
Yeah, it follows on from that. And when the CQC came back in, they inspected us against safe, effective and well-led. They were the domains that they focused on. The indicators for caring and responsive remain the same from the previous inspection, so that's why it's like that. But yeah, it follows on. It's the same chart.
Yeah. If it had been on the same page, it probably would have been a little bit easier to understand. The second point is with the action plan. I went through it and I looked at whose job it was to take the lead and as the lead director, and then who was to take the action lead. And you've got 5 different people as lead director, and then you've got 1, 2, 3, 4, 5, 6, 7, 8 people as action lead. With the workload and the items in the plan, how confident are you that that's been equally spread, or is there one person that's got quite a lot of responsibility? That does it carry the risk that it's too much of one person and therefore it won't be met?
So the way that the action leads are set out, it's within that person's area of expertise. So there will be teams underneath them supporting it to be able to deliver the actions. It's not just down to one person to deliver that. And we are confident that we will be meeting our action plan.
And then the last point is, this is something that is actually quite common to meetings. I was at a meeting last night and exactly the same thing was discussed. With something like this, I was talking to my colleague at LCC. For example, you don't need to look at the page, but say like 155, you've got the trust must take steps to improve EOC, PM 2.1 increase EMD. I noticed you said ARP. Could we have a glossary of terms, or well, I suppose there's 2 ways of doing it. The first one is you could say. You kindly explain them for me.
Via Google.
Via Google, yes, of course. So it could be like sort of, emergency department, now known as ED, or on page 1 having ED equals, just so that, we understand and we don't have to sort of question you saying, what does that mean? Thank you.
Thank you. Dr. Hill.
Thank you, Chair. On that last point, actually, if you were writing a boring academic paper and you mention the Latin name of something, or you use something as an acronym, the first time you use it, you put the acronym after, so everybody can refer to it. Anyway, that's just that's an aside. Generally, whilst it's not brilliant, it's getting better, and it's a lot better than it has been for some time, and there's some good stuff happening in here. So I just hope it carries on. We haven't got crises about moving the estate and all the sort of diversions we've had in the past. One thing that did cross my mind that I think I'd just like to know a bit more about is you've got an action here to do with frequent callers. Now, I know our local doctor's surgery had a thing about looking at their frequent callers, and everybody, I think, the police were doing this years ago, wising up to who are your frequent callers, because actually they take a disproportionate amount of resource, and generally they're people who need help, and if you solve the problems as well, you get the drift. I wondered how much you're doing that and cross-referencing your frequent callers with everybody else's. Because it's an issue across the piece, not just for you guys. I bet it's an issue for the GP, and it's probably an issue for a whole raft of people. And I just wondered, are you dealing with everybody else to deal with that problem? Because I bet if they were a frequent caller to you, there'll be a frequent caller to a few other people as well. Thank you.
So we have a central frequent caller team, and when we identify frequent callers, we have care plan, and the care plans are reviewed at an MDT meeting involving other partner organisations to try and work together. Multidisciplinary team, sorry. Yeah, so we do work with other health partners to review the care plans and identify to make sure we've got appropriate patient pathways.
If I can just follow up on that point as well, I point towards the work that we've been doing with the Braunston Blues team and subsequently then the Highfields Blues teams. And that was very much about focused around people who are high users of all emergency services and other NHS services and council services to make sure that we can work with them to signpost. And that's been very, very successful. So it's testing a new model.
Councillor Taylor.
Thank you. I'm just wondering if you can drill down the figures more for Leicestershire, because obviously this is East Midlands ambulance, and is there one area of that that's performing a lot worse that's bringing the figures down? So I just wonder how Leicestershire is actually performing with the new ED department and stuff like that. Are you able to pinpoint it a bit further?
Yeah, so I'll touch on ARP for a start off, the ambulance response programme. We've very recently gone live with ARP, as I say. We're only into the second full month of operating under the new standard so far. We are delivering at the moment generally at Category 1 our most critically life-threatening patients against the 90th percentile. So 90% of our patients are getting care within the predetermined window. Our mean time which we work to now, which it starts to get, we've gone from having 3 categories to about 10, but it is much easier to understand. Our mean time against a target of what will be 7 minutes, we're currently at about 7.5 minutes, 7 minutes 45 seconds against the mean. So actually, with the work that we know that we've got to do and with the additional staff that we know that we'll require, we're fairly confident that we'll be getting down towards that point. And our Category 2 patients are similarly there or thereabouts within the standard window. Now, we don't start reporting against those standards nationally until March 18. That's been mandated by the Department of Health to ensure that all ambulance services can move across and successfully start to work towards the new standards. Generally, that's a lot to do with changing models of reporting, back office functions like business intelligence teams having to rewrite rafts of reports and data reports. So that sits behind that. There's no smoke and mirrors involved with that at all. But yeah, we're very sighted on where our performance currently sits and where we're going in terms of a trajectory. So that's the ARP standards. In terms of the LRI position or UHL position for handover, I think it would be fair to say, yes, we had a very, very challenging position. We, in the first week of the ED opening, we lost somewhere close to just over 2,000 hours. And in one day, at its peak, we lost 200 operating hours, which just tipped us over completely. We had planned for a difficult period, but not to that extent. So it was challenging for us. It's fair to say now that they are significantly reducing that, and I will commend the work of the health community and UHL staff in terms of doing that. It needs to be a sustainable position, but it is much improved at the moment.
Any other questions from members?
Sorry, just we say you lost 200 hours. What specifically happened?
Okay, so we have on average 15 minutes to hand a patient over. That's the prescribed window. Anything above that 200 hours is classed as lost time. So if we handed the patient over after 20 minutes, we would have lost 5 minutes. In that one day, across all of the ambulance attendances at the hospital, we lost 200 hours above the 15 minutes, the 15-minute window. So you can imagine how difficult a day that was for us.
Thank you for those questions. I think looking at the report, I mean, it was interesting. My colleague picked up on you obviously Derbyshire, Nottinghamshire, Lincolnshire, Northamptonshire, all part of it, and I know you obviously cover Northamptonshire as well. But you know, it is Leicestershire, Rutland, and Leicester that we sort of we focus on here. So I think I found page 172, the whole report. The summary of findings is normally an easier read, but I found it more difficult than the actual detailed report itself. But there are some good outstanding areas. I think Dr. Hill picked up on that, and we wish you well on your journey. I think the only comment, the EMAS action plan you sent to us, which was dated March 2017, it might be just nice to colour code that with a RAG system, just to say these are now complete, we're there. It just would make it an easier read. But no, thank you very much for your presentation today, and thank you. And now we'll move on to agenda item 13, which is our Health Watch Leicestershire annual review. I will invite Rick Moore, Health Watch Chair, to move to the front if you'd like, sir.
Stay here if I may.
Are you sure?
Mainly about conserving energy at my advanced stage.
All right. Plus we have kept you waiting, so it's...
All right. Now, I'm always here for the duration. Thank you very much. Now, what I wanted to say really, Chair, was, bearing in mind the hour in particular, that I think and hope the report speaks for itself. Bearing in mind one or two questions that members have put to me, I wondered if I might just take an opportunity to give a little bit of background about Health Watch, because that really feeds in, I think, to the report and what we are. So Health Watches were created in the 2012 Act. They mirrored each unitary authority, so there are 152 nationally, and I am chairman of your Leicestershire Health Watch. As is often said about the film industry, we are a low-budget production. We are funded to the tune of 28p per person per annum. But that's not a complaint. We live in real times, and I hope that we punch above our weight. So what do we do? Basically, in the purpose of the report, part one, tells you what we're there to do. We're there to gather insight and information by whatever means we choose, and we go out into the community, and you'll see the number of people we've engaged with. We work out what matters most to people in health and social care, and there's a fairly big tariff, as you can imagine, but often it's around GPs, etc., etc., etc. We then gather information about those things to see that those comments we're getting from within the community are worthy of further examination, and then we hold service providers to task. We might, for example, visit a ward, a specific ward at Leicester Royal Infirmary, because we've heard a lot of people say that going to the ophthalmology department of LRI is a nightmare. And so we spent many hours there, and we saw that it was far from being perfect. We reported, we met with UHL at senior level, and we ultimately had a report back that £650,000 was being spent on ophthalmology and ENT. So that's where we believe we can make a difference. Health Watches are no more than the latest iteration of many attempts to have a watchdog. Our predecessor was Lynx, and before then there were two others, I think. And amongst our functions are the ability to report into Health Watch England. So there's 152 Health Watches plus a Health Watch England. Nowadays, even since 2012, Health Watch England really sits under the CQC, and we ourselves have powers of enter and view, statutory powers. We can go to any provider of health or social care services to inspect. We don't do the same inspection that a CQC would. It's different. Not got really time to go into it now. But I hope that very quick background with the report gives members, particularly, if I might say, newer members, some idea of what we do. We are a board of 10 volunteers, a tiny infrastructure. We're actually commissioned through VAL in our case, and our contract was extended and is now coming up for renewal. So there may be different people doing different things from April 2018.
Thank you, Rick. I mean, certainly I read through it. It's a very informative report. It's easy to read. It's in a good format. So I think, long may that continue. As I say, I did make note of the A&E, the Emergency Department report at the end of the pack, and I mean that again added my understanding of what we were dealing with today. So, do members have any questions? Just compliments once again, I think, Rick. Keep up the good work. Keep up the good work, and you looked well on telly the other night as well. So, yes. Agenda item 14. Reprocurement of integrated sexual health services, which are on page 247 to 252 of your agenda pack. Mike Sandys, our Director of Public Health, will present this report along with his colleague in Public Health, Dr. Joshny Mabji. So I'll hand over to you, Mike.
Thank you, Chair. True to my public health principles, I'm going to move to the front and use that energy. Even if I am old enough to remember CHCs, which of course predate by quite a few years. I'm going to hand over to Joshna to summarise the new model. So a brief introduction from me. Just to say the current integrated sexual health service, which we commissioned jointly with Rutland Council and Leicester City Council, that contract ends at the end of next year, 2018. So these are our early thoughts around the proposed model for the new service, which will be in place for the 1st of January 2019. So obviously some way off, but given the lead-in time for procurement processes and implementation plans, we are thinking about that model and consulting on the model now. So I went to Cabinet in June with a proposed model, which is important. There are some changes in there, particularly around the use of new technology. That's partly around making the service better for people, but it's an important part of our MTFS plan for the future years, because there are cost savings in the model that Joshna will take you through. We're currently out for consultation on the proposed model, and coming to scrutiny today forms part of the consultation before we report back to Cabinet in November for final approval. But I'll just ask Joshna to summarise the key elements, if you like, of the proposed model.
Thanks, Mike. Firstly, I hope I've passed on the acronyms and the abbreviations, because I hope I have done what was required. So if that's a tick, I'm almost there. In terms of the model, as Mike alluded to, the current contract ends December 2018. That gives us an opportunity to look at the current service usage and the activity, to decide the best way forward to ensure that we meet the varying needs of our population, because obviously things will change over time. So we started off by looking at the service usage. In terms of the way the service works currently, we've got two main sexual health service clinics. One is St Peter's Health Centre in Leicester, and we've got the Loughborough Health Clinic, the clinic in Loughborough, which is at Loughborough Health Centre. And then in addition to that, we have spoke clinics. So these are clinics run once or twice a week for about an hour, anywhere between an hour to 3 hours, depending on the clinic and the location. We've got 4 in Leicestershire, 12 in Leicester City, and 1 in Rutland. These are for all ages. That's the current model. When we looked at the service usage, we found that the majority of attendances were to the Loughborough Hub Clinic for Leicestershire residents, so that's 55%, more than half. And then we had 36% to the Leicester City Hub. So in terms of attendance to the main hub clinics, that's 91%. So that's most of our service activity. In addition to that, we had about 8% going to the sessional clinics, and then 1% to the clinic in Rutland. So looking at that, we were looking at potential changes in the way that the service is delivered going forward. In terms of who uses the service, young people are our most frequent users. So 48% of all the service activity by Leicestershire residents was by those under the age of 25. And again, that's key for the proposed model going forward. The other aspect we were looking at is sexual health related contracts that we've got in addition to this one. So we've got contracts linked to condom distribution, pregnancy testing schemes, work around sexual health promotion and HIV prevention, and it made sense to use the opportunity to try and pull all those contracts together to provide one service, because essentially they are doing a lot of coordinating work, and it made sense to, if we can pull it together, to pull it together. So based on that information, and also a sexual health needs assessment that was undertaken and a sexual health strategy that was developed, we pulled together a proposed model. What we'd like to do is to keep the main clinics in Leicester City and Loughborough. So those current services would continue. The sessional clinics, we propose for the sessional clinics, which are currently in Colville, Hinckley and Market Harborough, to be retained, but to reduce the opening hours. And part of this is because we propose for those clinics to be made available to those under the age of 25 only. So we're saying by reducing those that would attend who are over 25 to the current service, we'd be able to justify a reduction in the clinic opening time. We're proposing a closure of the sessional clinic in Melton, and that's predominantly due to low usage. The closest alternative sessional clinic will be in Oakham. Again, we looked at the usage of the sessional clinics, and Market Harborough also had low usage. But looking at the geography, if we proposed to close that clinic, the attendances, the people would have to travel a lot further than closure of the Melton clinic. At least we've got the Oakham clinic in terms of accessibility. We've also wanted to focus more on increasing HIV testing, looking at targeted promotion of online testing. So in addition to the current service that we're proposing is to provide online access to ordering of self-test kits for sexually transmitted infections, for HIV, for pregnancy test kits. And that will hopefully again improve accessibility, particularly for those who struggle to get into clinics. We're also proposing, at the moment we're planning to pilot the use of sexual health vending machines. So these are machines that you can put in community venues. They're accessible for individuals to access sexual health products such as condoms, pregnancy test kits and sexually transmitted infection test kits. We're proposing to increase the access to information advice services, and that's through development of the sexual health website. We're proposing to have telephone advice lines for support, and all of this is looking at reducing the need for face-to-face consultations for certain aspects of sexual health services. So there are aspects where people are attending for contraception or for accessing condoms, and we're saying that that doesn't need to be a face-to-face consultation with a clinical professional in some cases, not all, and whereas those that are a bit more complicated or where there are safeguarding issues, they still have the sexual health service that they could attend. Everything. So part of this, as Mike has alluded to, we've commenced a consultation which commenced on the 21st of August with a view to seeking feedback regarding this proposed new model. This will be running for 8 weeks and is done jointly with Rutland and Leicester City. We've already done drop-in sessions around all some of the clinics, sessional clinics so far, and had some feedback already, and that will be available. We're planning to do a mid-consultation report in a couple of weeks just to see the feedback that we've got so far and ensure that we've targeted appropriate groups. If we find that we're missing certain groups, we'll then target those up until October. That's it from me.
Thank you for that. Questions from members? Councillor Bedford.
Hi, I'm not a health professional, but just some articles that I've read over the last couple of years. You mentioned here about the introduction of some age-restricted sessions in some of the clinics, and also you mentioned some targeting of particular high-risk groups. one of the risk groups that I certainly read about in the last couple of years was the actually older age range, 50 onwards. What's being done to address that area of risk now?
That's a very good question. The sexual health clinics, the main hub clinics, that service is actually an open access service. So we're not restricting accessing of those services. What we're saying is that for those individuals who are in the higher risk group, which when we did the needs assessment, we identified that the highest rate of sexually transmitted infections was actually in the under 25 age group. So we're trying to cater for that age group regarding the sessional clinics, and what we're saying is that the population as a whole can access the GP. We do have the hub clinics, the Loughborough hub, the Leicester City hub, the Oakham hub will remain an all-age service. It's just that we're saying that for specific areas we want to make it an under 25.
If I can come in, Chair. I mean, again, I think it's worthwhile knowing that the re-procurement gives us an opportunity to work more closely with CCGs, because there are elements of sexual health which are a core responsibility of the GPs within their GP core contract. So it tends to be that if you're over 25, you're probably more, the acceptability is you're more likely to go to your GP because you're more able to discuss your sexual health, and there isn't the element of embarrassment. For instance, if you're under 25, going to your family doctor and family members or other people seeing you in the GP practice. So one of the things is to recognise that there are some issues with older people, divorcees, having sex when contraception isn't required, for instance, because you're a bit older. This enables us to have a sort of a conversation which is along the lines of what's more appropriate to go to a GP and what's more appropriate to come to the specialist sort of end of sexually transmitted infection that we're responsible for. So there's also the system bit in there as well, as which kind of picks up a little bit the issues around age as well.
Another quick question, just on a similar point around risk groups. Another risk group that I've certainly become aware of anecdotally through conversations with a lot of practitioners that I know in Leicestershire and the region is around minority communities, particularly Asian communities, around risk of infection, sexually transmitted diseases. So is there further work being done on targeting specific groups like that as well through this new process?
An element of the sexual health service re-procurement is about targeting at-risk groups. So one of those, again, in terms of going back to ethnicity, we were looking at the black, I think it's Black African community. As one of the high-risk groups. So what we're trying to say is by putting in the promotion work as part of the integrated service, one of their roles will be to do promotion work to at-risk groups by identifying and targeting. And I know currently we do have one for certain at-risk groups, but that'll be something that we'll do going forward.
Thank you. Councillor Taylor.
Thank you. My issue is just picking up on the vending machine issues. I mean, are they likely to be put in areas that are private? So if they're in community centres or GPs, etc., I'm thinking of people going to get condoms or pregnancy tests in a public arena is probably not. So, there needs to be some thought about where those vending machines are placed, and also the cost of those products. Are they going to be similar costs to what you could buy in a supermarket or a chemist, or are they going to be free, or what's the sort of the price range of those vending machines?
So the first question, we are planning to do a pilot of the vending machines before we decide whether we're going to be including it in the integrated sexual health service re-procurement going forward. What we're trying to do, one of the areas that we're trying to pilot that is the university, Loughborough University. As one of the examples. The second machine, at the moment, we're trying to do a scoping exercise to see where would be best place. So that will involve us going out to look at potential sites, working with those who are out in the community who may have sites that they have in mind that would be useful. The machine itself, although I say vending machine, it's not the vending machine like drinks where you see all the products on display. It looks more like an ATM machine. So the products are discrete, and the machine doesn't have a banner over it that says sexual health vending machine. So we're trying to work with the companies from that aspect as well. And did that answer the vending machine question? Did I miss anything on that one? Yeah.
Just to come, is there councils that are already doing this?
Yes.
That you're following a model from?
Yes, so Teesside, I believe, have already got them in place. So we, again, part of the scoping is to work with them to say, what have they done, what did they identify, how have they dealt with safeguarding, for example, how does it work in terms of linking in with the sexual health service data so we know who's coming. The other bit I just remembered was the products. The products will be free. So it's linked into, the idea is that the machine links into the sexual health service clinic information so we can monitor who's using it. If obviously we can't stop people from putting in incorrect information, falsifying information, but we can do things to the best that we can. But the products inside will be free. So there'll be no cost to the individual.
Is there some way that if you're going to do these services online, so someone could ring up or go online to say, I need to do a pregnancy test, that you can give them a reference number that then can be put into a vending machine? So or is it just going to be free for all, for everybody, just to put their date of birth in, their details to get what product they want?
That's the scoping work that we're doing to see firstly how Teesside have done it and to find out if there's anybody else that's done it and how they've done it. But also, if we were to do it, we need to make sure we know how this will link in and also improve the way that they can be accessed. Part of the work, again, around the online access, so by ordering, we're looking at, again, things like a click and collect to see if they can obtain the kit from a discrete place rather than having it delivered to the house. So those are options that we're scoping out at the moment. We're in the early stages of it.
Go on. And if I could just come on that, just to cover the cost bit. Clearly treating people with an STI costs money. It's a large part of our budget. It's worth it to some, well, it is worth it to distribute condoms as freely as we can because they're cheap to prevent people washing up in the service in the first place. So it is largely an element of demand management on our part. Clearly, as Josh just sets out, it's also an opportunity if people are willing to share their information with how the vending machine works, to then engage with people who are maybe high risk using condoms, or indeed for younger people who maybe don't want to go into a chemist and buy their own and would rather engage through a discreet bit. So it's a bit of engagement, but actually rather than, I wouldn't want to give the impression we're distributing free condoms and encouraging people to have sex willy-nilly, to coin a phrase, but it is really about demand management on the service overall. So that's, the payback is immense.
Brilliant idea, and I hope we can, that it's safeguarding everybody, but also freely for use, and it does what you want it to do. So I think it's a really good way forward. I hope we get some information from Thank you.
I apologise profusely, but I've forgotten your second question.
No, the cost.
Oh,
so you answered it, yeah.
Sorry, yeah. Okay.
Councillor Parton.
Yeah, this question does continue on the subject of condoms. You were saying that part of the service is distributing condoms, but in terms of the education process, are you seeing repeat people coming simply to collect condoms, or as part of the education to say, well, are you coming here because you can't afford them? Or is it merely a service where whoever comes, if they need condoms, they will receive them?
We have a process for individuals who do go to seek condoms. So we have a scheme called the C Card scheme in addition to this service, where individuals are trained, and those individuals who want condoms will go to see the trained person, and they're assessed to see what the reason for this is, to make sure that they're competent in understanding why they're having these condoms. So it's not just something we're just dishing out to people. Once those individuals have been assessed as competent and understanding the service that they're accessing and what they're doing, and they understand sexual health behaviours and protecting themselves, they then are approved and receive a card that's almost stamped in the way that you would when you go to Nando's and you get the stamp for spending £5, which is probably the worst example to give. But so they get an allowance, and then once they've met their allowance, they have to be reassessed. So if that allowance shows that they've sought condoms within a short space of time, that would raise a safeguarding issue, because it would say, well, actually they've had 10 stamps within a month. There's something not right there, and we can then investigate further. So it's not just them coming to a site and then having it distributed. It would be a mechanism of ensuring that they're safe.
Right. So, on a more serious note, the most common age group is under 25s. The question is, that's the final number of the age spectrum. What does it begin at?
Our youngest service user is, I do have that, I've got it down as under 15 actually, so I don't have that information on the top of my head, but I can find out.
Are we talking the sort of, if this is the common group, what is really your largest number of your beginning range that you're seeing on a regular basis?
It's 20 to 24. It's a 20 to 24 age group, followed by the 15 to 19.
And one final procedural question, if I may. Obviously, you alluded to this because obviously there's two centres. There's one in Leicester, there's one in Loughborough. There's obviously two universities in Leicester, and there's a very large one in Loughborough. Does Loughborough University at the Medical Centre have its own sexual health clinic and services where students on campus are put, even living off campus can go, or because of the number that are presenting at Loughborough, are they non-students or is that Loughborough students as well?
The Loughborough University has currently its own sexual health service within the GP practice. That at the moment is funded through the clinical commissioning group, so I couldn't comment on the future of that. However, the Loughborough usage, because of the transport links, that's the reason for the usage of that across the board. It's not just the university residents. It's all residents around the area.
Or from anywhere else.
From anywhere else as well. So we do get city residents going to use it as well.
Thank you.
Thank you, Chair.
Councillor Hagg.
Just obviously we've already mentioned the universities, is what connections there are into the FE sector. And also, is there any sort of link into the food banks? Because clearly if people are unable to need to go to the food bank, they're obviously unable to afford condoms or contraception. So is there any links that we can make there?
With regards to the links to the education system, we have a section of the current service which we are planning to continue is the Choices Clinic. So these are clinics for the under 25s specifically. But the difference with that and the proposed model is that these are actually based in settings like educational settings. So the downside to that is that it's only the students that attend that college or that school that can use that service at that point in time. So what we're saying is that by having it as an open access for the under 25s, this will also add to that. That's not planned to change. We plan to continue with that. Sorry, what was the next bit? Food banks. That's a really good question, actually. It's not something that we've considered, so I will take that forward. I think that's a very valid point.
I think it is the other bit that springs to mind is, of course, the Scrutiny Commission looking at poverty per se, and again, it's probably worthwhile making the links around general impact on our services, because obviously there's a range of services that people may not be able to afford and what effect it has, but it's a good point. Yeah.
Okay, thank you. I notice in your report you're taking the consultation, the outcome and the final delivery model to Cabinet in November 2017. We have a scrutiny meeting here on the 8th of November. I'd just be curious what the outcome of the consultation was, because obviously that to me is of interest, whether it comes back as a pink paper, but I'm sure members may be interested to see what the take-up and what the success was based on what we've seen today and other consultation papers that have been tabled. It would have just been interesting to see that, and if it is a pink paper for information, it might just be an interesting...
I'm looking at Josh now. I know times are tight in terms of turning around the consultation report to Cabinet, but I would imagine by the 8th we'd have... I mean, it'd be the draft Cabinet report, actually, wouldn't there, that could come? I'm looking at Rosemary.
I know as members we have access to the Cabinet system anyway, and we can report back through anyway, but it's just out of interest. All right. Okay.
Yeah.
All right. Can I thank both Mike and Joshna for that informative report? And it's yes, thank you very much. Final report, agenda item 15. This is the protocol between the Leicestershire Health and Wellbeing Board, the Leicestershire County Council Health Overview and Scrutiny Committee and the Local Health Watch provider. Pages 253 to 272 of your agenda pack. Rosemary is going to present this. Would you like to remain seated there or would you like to move to the front?
I'll stay here if that's okay. Thanks, Chairman. So first of all, apologies, there's an error on the report. The protocol is obviously not considered by the Health and Wellbeing Board yesterday because it doesn't meet until the 21st of September when it will be considered then. So it's the other way round. The outcome from this meeting will get reported to the Health and Wellbeing Board. And we're also hoping Health Watch will consider this in September. This protocol was first produced in 2013, just at the time when Health and Wellbeing Boards and Health Watches were set up. So we thought it was timely to revise it, considering that there's been quite a few changes, such as the introduction of STPs. So when we wrote it, originally, it was more about how we expected things to work, and we've now been able to revise it with the benefit of hindsight, talking about how things actually work. So the info about the roles of each body is drawn from the terms of reference. I've then put in a couple of examples to illustrate how the relationship between the three bodies should work in practice. Obviously, because the STP covers LLR, Leicestershire and Rutland, although I've put the STP as an example, and we might want to consider whether it would be better to convene a joint health scrutiny, but the principles would be the same regardless of whether it's our health scrutiny or the joint committee. So by bringing this here to you, it's an opportunity for you to ask me any questions about how Scrutiny, Health and Wellbeing Boards and Health Watch work, which I'll do my best to answer. And I'm also asking for your approval subject to any comments made by Health and Wellbeing Board and Health Watch. Thank you.
Okay, thank you, Rosemary. I mean, I found the working principles on 263 and the examples given, sort of guided me through the process and how each of those organisations would deal with any problems that they were asked to comment on. So I had no issues with the documents, but I'll open it to members, and obviously Rick as well. So it's any comments or observations, concerns? No?
Trying to understand it, really. There is no one that guides the other. All three are trying to find what common ground, because obviously this Venn diagram, you've got something in the middle of all three, or are you looking for two to inform the other, or once three have given information, is something disseminated and think, right, well, okay, what can all three mention this? That's what I'm trying to tease out here.
Okay, I think I can answer that. There is no one body that is responsible for the others. They all exist separately with their own separate statutory functions, but they're all essentially trying to do the same thing, which is to improve health and social care outcomes for people in the local population. So they all have a slightly different role, but it's all moving towards the same outcome. So in order to make it work effectively, we thought it was a good idea to write a protocol to try and explain what the role of each body is and how they could work together to be more effective in terms of achieving those outcomes. So in the Venn diagram in the centre, each of those committees, bodies, should be intending to work in a climate of mutual respect. They all have a role in monitoring performance. It's helpful if they all have a shared understanding, which is partly the reason why Rick comes along to health scrutiny meetings. He's also a member of the Health and Wellbeing Board. It also helps that I, as committee officer, support the Health and Wellbeing Board. Mike Sands is on the Health and Wellbeing Board, and he's obviously here trying to advise you. So we try to make sure we've got a shared understanding. But all of the bodies are also independent, and we have to respect that. So we can't tell each other what to do or force each other to do anything. And we try and share work programmes. So obviously, because I support Health Scrutiny and the Health and Wellbeing Board, it's quite easy for me to share my work programmes with myself. But I meet with Health Watch to make sure that I share both those work programmes with Health Watch on a quarterly basis as well. I hope that kind of answers the question. It is quite a tricky one. Mike, you look like you have something you want to add.
If it's helpful, I thought the diagram was actually quite useful. I like the little labels that lay outside the circles, because I thought that describes what's the doing bit. So in terms of scrutiny, questioning senior manager and considering service changes, we've seen that this afternoon, compared with the sort of more strategic developing the health and wellbeing strategy through the Health and Wellbeing Board. I actually thought those labels in terms of what are the tasks that are being required of the three different bodies was quite useful. Sort of, we've got a common purpose, but we transact it in slightly different ways. I thought it was really useful.
Okay. No other questions? Okay. I think because you sort of sit on two bodies, and obviously the third is Rick. I'm sure Rick feels happy that he is advised on a regular basis, and from a Health Watch point of view, so it's okay. Right. No, I think I'm happy to say well done to Rosemary on that. It's a good protocol, and I'm sure those are the comments going forward. So thank you for that. So. Agenda item 16, any other items which the Chairman has decided to take as urgent. As I've said previously, then there are no urgent items. The only one I would mention, we are new to this, many members. The pink paper's at the back, there is a box on it which does say, please contact the committee officer if you'd like to see a further paper on the issue included on a future meeting for discussion. There are two papers there. I know one, I think because of the length of this agenda, one would normally come through, which is the quarterly performance. So we will, I presume, possibly see that, or a summary of it at least. But as I say, just again, compliments to Health Watch. It was a good paper, and I enjoyed reading that. So it's thank you for that. So, date of future meetings, agenda item 17. There was an error on which Ewan has picked up and Rosemary has picked up. The date of future meetings are listed on your agenda. However, there was a typo. There's one meeting in January, which is on the 22nd. And there should be one meeting in February, which is on the 28th. So the agenda paper said there was a meeting on the 22nd and the 28th of January, but if you note the correction, and thank you for that. And with that, I will thank you all for your attendance and close the meeting at just gone 4:30. So thank you ever so much for your attendance. Safe journeys home. Thank you.